Hello everyone, we are back with Dr. Graham Bays today. He's going to chat to us about the ACL.
The anterior cruciate ligament, as a side note, is the most studied ligament in the body, simply because it's quite complex in its treatment. But if we just go through the basic anatomy, in the middle of the knee we've got two main ligaments that supply stability. So the anterior cruciate ligament is the most frequently injured ligament, and that's the one that's most spoken about. And just for completeness sake, we'll show you that at the back of the knee you also get your posterior cruciate ligament. Now, the anterior cruciate ligament is comprised of a number of bundles. I won't go into the details now, but essentially it's got two main functions. One is that it prevents the knee from going forward, and the other component to it is it also provides rotational stability. So it doesn't run directly from anterior to posterior, it runs at an oblique angle as well. So that's why it provides two functions, not just one. So the mechanism of injury, so there's different types of injuries. So the one that we most associate with is if you get a vulgar stress, so you stress it like that, and you get external rotation and flexion. So you can just see that with the model there alone. So essentially what happens is that the ligament ruptures, and the pivot that the patient feels usually is when the femoral condyle actually subluxes posteriorly, the ligament ruptures, and then it sort of spontaneously reduces itself.
So will a patient feel immediately if the ACL has gone? Like would you hear something pop or snap, or would you feel unstable?
Yeah, so the very common theme there is a patient will tell you that they felt a pop or a click. They fall immediately to the ground. It's usually during a sporting event. They're usually unable to continue, and swelling occurs within 24 hours.
So often it's not just the ACL that goes, it's other structures as well. Tell us about that.
So last time we spoke about meniscus injuries, and that's exactly the other structures at risk. So usually with first time ACL ruptures, the most commonly injured meniscus then would be the lateral meniscus. But because you get that instability long term, you can get medial meniscus tears as well. Of course, you can injure other ligaments. You can injure the medial collateral ligament, you can injure the posterior lateral corner, which we may discuss at another time. But the most common thing is that you usually get meniscus tears with it.
So tell me about the different grafts that you can use, and what's the most common used one?
Okay, so essentially there's three main graft types. So it's autograft, which means it comes from the person itself. You can use an allograft, which means it comes from cadaver tissue or from another person. And then you can also use synthetic materials. So those are the three main grafts that we use.
Which do you prefer using?
So autograft is the gold standard. There's various types. So you can use your patella tendon with the bone block on each side. You can use hamstring tendons as well. You can use quad tendons. Those are the most commonly used ligaments.
So we know that the ACL recovery is 9 months, so it's quite long. And look, it's a scope that you do, but it's still quite an intense surgery. So explain the surgery to us. What do you actually do, and why does it take so long for a patient to recover?
Okay, so it's quite a long question that you asked.
Sorry.
So I'll take from the beginning. So you have to establish the correct patient that you're going to do an ACL reconstruction with, because like you said, it is a 9-month commitment before return to sport. The simple reason for that is if you return to sport before that period of time, we find that there's a high re-rupture rate, as much as 30%. So if you're going to do an operation that's not going to work 1 in 3, then you shouldn't do it at all. So you have to have a patient buying into it. You have to have a patient that's fairly active, because a lot of patients don't actually need an ACL reconstruction. If you're a sedate sort of individual, sort of gets up and down the couch, and you sort of have a normal sedate job, you don't really need it reconstructed. So it's more your highly active individual that's going to do twisting, turning activities.
Will that, if you don't reconstruct it, will it not cause issues later on in their lives?
It may or may not, So we know that the patients that you leave alone, they have around about a 50% chance of developing osteoarthritis and developing or OA and getting a knee replacement in the future. But it doesn't mean that you get an ACL reconstruction that you're guaranteed not to go on to develop that too. So it's more about function and lifestyle and what that patient's expectations are. So if you decide you get a good candidate, the surgery, like you said, is done arthroscopically predominantly. But I always tell my patients you're going to have a few scars. So for me, you'll have a scar just in the lower leg here. That's where I'll harvest your hamstrings from. I fold it up into a graft that's more or less the size of a patient's pinky finger. and we drill the tunnels anatomically through the tibia or the bottom bone, and then it just depends on your philosophy. I like an isometric graft. We won't get into too much of the technical details on the femur, but essentially what we see on this knee model, that's exactly how your graft will sit.
Okay.
So the idea is, the goals are, one is that you want to restore two things, the two functions that we spoke about. We want to restore that stability in the anterior-posterior translation. We also want to make sure that there is rotational stability as well.
How long does that graft take to integrate with the bones, I suppose?
Okay. That's a great question, and you put it quite well. So the idea of when we of putting the graft in, so essentially what we do is that we take a stripped piece of tendon. It's got no blood supply or anything.
Yes.
And once you secure it in there, then the body has to do the rest.
Yeah.
So what you're asking is the physiology behind that is that it takes a full 12 months to actually integrate itself.
Okay.
The younger the individual, so some people would argue that if you're really young and really active, so in other words under 25 years old and you are a sportsman, you should probably wait about 2 years.
Okay.
But we know that's unacceptable for a lot of patients. Yeah.
Okay.
So we wait about 9 months, and it's only really animal studies. You can't really do it on humans. You won't get ethics for that. Is that we see that it takes at least about 9 months or so for the graft to get really strong and to be able to sustain normal forces.
So that's why it's so important that there's certain things that you can't do at certain times. So when we rehab a patient, we get the patients normally at 3 months. We do a cervix test, but an open chain movement is something where your foot does not plant on the floor, it's not secure on the floor. And that stresses the ACL more. So up to a certain period, up to 5 months, we tell the patients that they're not allowed to do any open chain movements because you put the ACL under strain. You're also not allowed to run too quickly. There's certain tests that we do to make sure that you are able, your muscles are strong enough to handle that. So I think, I think we can talk a bit about people not doing the rehab protocol, not following the protocol.
So if you ask any knee surgeon, you're certainly going to see those patients. So like we said from the beginning, you have to get the compliant patient that's going to buy into it, because the restrictions that we put on patients, like you said, is that the whole program is about protecting that graft until it matures and is able to sustain those forces. If you go back too early, the problem is that you've only got a static stabilizer, which is that ACL, and if that graft is weak, and it's usually weakest at about 3 to 5 months. And this is when patients actually feel the best and they feel they can go and do these normal acceptances.
So that's quite important, between that 3 and 5 months. I think it's also the time where they sort of fed up now because they haven't done much for 3 months, and now they want to start going back to sport or their normal activities, and like you said, they start feeling better at 3 months. Would you say that that's sort of the period that they normally re-tear it, or would it be later on?
So from 3 months onwards, if they're not compliant and they return support, that's exactly, because the graft is at its weakest at that stage, so that's when they usually re-rupture.
So how long before the patient can play golf again or go back to sport? Is that the 9-month mark?
Minimum 9 months.
About? Okay, all right.
So the interesting stats, so if you look at patients who return to sports, if you undergo the rehab program and you get all the parameters correct, your re-rupture rate is less than 10%.
Okay.
Your return to sporting activity of the same level or higher is around about 80%. Now the problem I tell patients to try and scare them into following the program is if they have the re-rupture, yes, you can redo the ACL, called an ACL revision. But then the return to the same level of sport or higher is less than 20%.
Sure.
So the stakes are high. So when you get these sort of high-level athletes who are, want to return to sport as quick as possible, they have to understand that if they do not follow the protocol, it could be career-ending.
Okay. Thank you.